But for me, one of the things I really like doing is interacting and getting people to give me feedback and ask questions about what they're really interested in. Because sometimes I meet with people that are, as an example, I was at West Virginia and there was a group of ophthalmologists there, and I got a chance to talk to them about specifically more about CTX and cataracts and refsums and eye changes in those diseases and how therapies that we offer may be beneficial for those conditions. So by all means, if I don't cover something that you're interested in, ask me and I'll try to respond to you, okay? How many of you were at my talk on Monday? Yes? Yeah.
Not me, sorry.
We were in Colombia.
You were in Colombia. Okay. So to start with, this is the bile acid synthetic pathway. And I joke about the fact that, oh yeah, you should memorize it and know exactly what the steroid structures are. But that's kind of a joke. My collaborator, Ken Setchell, he knows all of these in infinite detail. And I say, physicians don't care about this. They want to know the basics and carry away from this what are the most important facts. So if you look at this diagram here, there are two pathways. There's a classical pathway, this brown pathway, and this acidic pathway. And the most important thing on this pathway from our standpoint is this particular enzyme right here, which is CEP7A1. That's the rate-limiting enzyme of bile acid biosynthesis, and that's the principal enzyme that we're attacking when we give a drug like cholic acid. So the defects that we think are the most important ones for the clinician who's going to see patients in practice are basically these two right here. That is 3-beta-HSD deficiency, which is beta-hydroxysteroid dehydrogenase isomerase deficiency, which is a long term, and then 5-beta reductase. Those are conditions you're likely to see. The other conditions, this condition here you might see with a very ill infant, the oxysterol 7-alpha hydroxylase deficiency, or CYP7B1, but we don't know for sure in our hands whether cholic acid works for this. And the reason it works is because it attacks this enzyme right here and suppresses synthesis so that the toxic materials that are produced upstream for the defects are no longer produced, and we're producing a pool that actually allows the patients to have a pool of bile acids, to have normal bile acid secretion and absorption of fat and fat-soluble vitamins in their gastrointestinal tract. Okay? If I don't cover something, ask me. So this is what our experience is. That's the reason I told you these two things is these are the two most common defects we see. The third most common thing we see is proximal defects. And I have to go back and show you from this slide where those guys hang out. They hang out down in here. And those can be either single enzyme defects or they can be transport defects. And the most striking of these is probably not Zellweger's and maybe not even neonatal adrenal leukodystrophy, because those conditions tend to be fatal relatively early in life. Whereas kids with infantile refsums, they live for a long time and they may benefit from therapy because of the liver dysfunction associated with their disease. And in contrast to what I told you about these two compounds here, we think we know categorically this compound here is toxic, but we don't know the compounds above 3-HSD are. We believe proximal defects that there are cholestanoic acids that are produced because there are basically side chains that are not cleaved here, and those compounds probably are mitochondrial toxins from what we can judge. So the diagnosis can be made a couple different ways, and this is the archival way. This is the way we're still doing it at our institution by what's called fast atom bombardment mass spectrometry. It's a long bunch of words, but probably now LCMS by electrospray is probably the more modern method to do this. And it should be relatively straightforward in good laboratory hands. The typical pattern that we see is the principle of FAB-MS is basically that you bombard an atom with an atom gun, a drop of urine, and then you get a typical fingerprint of that specific defect. And to sort of to back up for ever so slightly, these defects, the ones that are the most important to the clinician, remember, the defects, those tend to have or do categorically have low GGT cholestasis. We learned this some time ago. When we first started doing, we had no idea about GGT. And we learned that GGT is suppressed in those particular patients, just like it is for PFIC1, 2, 4, and 5. So it's part of the differential diagnosis for those conditions. It's not for PFIC3, nor is it for Alagilles, because PFIC3 and Alagilles typically have very high GGT levels. It's probably even for the cholestatic form of alpha-1 antitrypsin deficiency, they tend to have high GGT levels. The piece that we also recognize because it's part of the spectrum, that clearly biliary atresia is going to have a high GGT cholestasis as well. And you're likely to see high GGT cholestasis associated with TPN cholestasis as well. So it's actually a fairly narrow differential group of diseases that you have to think about. But it's important to think about them. And I think it's also important because I think we're going to learn over time that even though we're using FAB-MS or electrospray to make the diagnosis, it's going to be increasingly important to know what the genetics are, not only for these diseases, because currently we don't know about any phenotype-genotype relationships. However, in the future, there may be forms of PFIC1, 2, 4, 5 that are part of the differential diagnosis where specific mutations may be amenable to specific therapy, even though we don't have it right now. So as an example, you could use an example of phenylbutyrate as a good example. Phenylbutyrate could be a chaperone that would help a misfolded protein to get to the surface to help correct one of these defects. This is not true in this condition, in the bile acid synthetic defects yet. So this is just basically the pattern. I'm showing you this not for you, more for your entertainment than for anything else, just to show you what a normal cholestatic baby would look like and what a normal newborn would look like, and what the fingerprints look like from these diseases. And specifically, these again are the metabolites that are produced upstream of the block. And the ones that we focus on mostly are these two here. Here is 27-hydroxylase deficiency, which is CTX. And here's the oxysterol defect. But, and if I were to show you the pattern of a peroxisomal disorder, you would see a very long chain, side chain bile acids that would be fairly characteristic of peroxisomal disorders as well. So the alternative way to make the diagnosis today is by gene sequencing. And I'm showing you this only because I'm not familiar with what you have available in South America for gene sequencing. In the United States, there are basically two large laboratories that are doing these analyses. We do a thing called the jaundice chip in Cincinnati, which has a limited number of defects on it. And Emory now has a cholestasis panel that has 66 different genes on it. So it contains, many of the PEX genes for peroxisomal disorders. It contains, you go through the differential diagnosis, alpha-1, Alagilles, all the PFICs. It even has acid lipase deficiency on it. So there's a number of things. And this is a test where we've been talking about this for the last couple days. And Paul and I were actually trying to figure out what would be a strategy to send samples from South America. And it probably would be the strategy in the United States is if they don't have biliary atresia and if they don't have TPN-related cholestasis and there's no other modifier that tells you you should send a urine for testing. The only thing I would probably add, at least in South America, might be a low GGT. And the other thing you could do, if you have it available to you, is serum bile acid measurements. So by conventional techniques, these patients who have 5-beta reductase and 3-alpha hydroxy or 3-HSD, both of those conditions are going to have normal serum bile acid concentrations. That's not necessarily true about Zellwegers. They may actually be high, but you know, phenotypically, we all pretty well know what a Zellweger's patient looks like or a patient with Revson's because they have fairly characteristic phenotypes that we can identify.
But for those, we can analyze very long-chain fatty acids.
You can, that's true. You can do very long-chain fatty acids. You can do piperacolic acid, prostanic acid, vitanic acid, any of those would actually help you because those defects share a common pathway for bile acids as well as fatty acid metabolism. Absolutely. So I think from my perspective, probably the most important take-home message is the differential diagnosis that you're looking at predominantly for inborn errors is going to be, and specifically 3-HD, SD, and 5-beta reductase, is going to be PFIC 1, 2, 3, PFIC 1, 2, 4, and 5. And probably not a lot of other specific things. And as I said, you can make the diagnosis by urine testing. And again, typically they have a low GGT, and they will present with neonatal jaundice. Probably the piece that we've learned, and I think we're going to learn more in the future, is that the median age of diagnosis of 3-HSD in our registration trial for the FDA was 4 years. The median age of diagnosis for 5-beta reductase was 4 months. So it appears as if there are patients who are way beyond infancy that we're identifying. And there's actually a paper that was published in Hepatology that I referred to the other day where there's some adults that have been identified who have idiopathic cirrhosis. And I think that's another field in which you may think about in terms of getting a history. If a child has prolonged jaundice in the newborn period and they have unexplained liver disease, you might consider testing them, even if they don't have jaundice. The important thing also is to remember that although there's a temptation to use urso because it's really cheap, urso, unlike cholic acid, doesn't suppress cholesterol 7-alpha hydroxylase. So you may lull yourself into a sense of security that you're treating the patient well, and they may have ongoing smoldering disease and end up having cirrhosis if you don't treat them with cholic acid. So one of the things about urso is it's actually marketed for treatment of PBC, and originally, obviously, you know, it was marketed for gallstone dissolution, which became sort of insufficient in terms of an indication. But it turns out that urso may actually enhance cholesterol 7-alpha hydroxylase activity and enhance the production of metabolites. You may develop a more favorable milieu and actually improve your enzyme concentrations in the serum. However, there still is going to be an ongoing injury to the liver. The unfortunate thing is, as of right this minute, once we identify these patients with one of these defects, this is a lifelong sentence of therapy. They need to be treated indefinitely, and we know if you take them off, they'll develop, their transaminases will go up, and they'll have evidence of injury. And we actually have done some of that inadvertently or by basically non-compliance. We've been able to demonstrate that in our patients.
What about in CTX patients?
What about CTX patients? So CTX is a disease that's predominantly a disease of adults. It is a disease that actually is a bile acid synthetic defect, which was described back in the 30s. It was recognized that patients have development of xanthomas in adulthood. They develop cataracts in the second decade of life or even the first decade of life, and they have diarrhea. CTX historically has been treated with chenodeoxycholic acid. We have a limited experience using cholic acid for infants that we've identified with the defects because we think, at least I think Ken and I both think this, that because babies are born with what we call physiologic cholestasis, where they have poor uptake of bile acids by their ileum, They have poor uptake of their bile acids by the basolateral membrane. Their canalicular transporters are impaired, and their bile acid pools are relatively small, and they don't synthesize bile acids well. We think they're prone to insults that probably wouldn't affect older patients. So as a consequence, we believe that maybe makes them more prone to have cholestasis in the newborn period. Now, when I say historically they have been treated with chemo, these have been adults who've been identified with full-blown disease. That is, they have xanthomas and they already have obvious neurologic disease. For our patients that we've treated, and there's a limited number of them who've been treated, we've treated them with cholic acid. And the question is, which one might be superior? The answer is, in the end, there's more experience with chemo, but here's the pros and cons. Cholic acid is a drug that we have a long experience with, particularly in children, and we know that it has relatively no toxicity. You may have a little bit of diarrhea associated with it, but that's probably about it. On a molar basis, chemo is probably superior to cholic acid in terms of suppressing synthesis. However, in the doses we typically prescribe, which is 15 milligrams per kilogram, they're probably pretty comparable. So as a consequence, there's probably no selective advantage to using chemo. Because in theory, what you want to do with CTX is you want to suppress the production of cholesterol, which is a bile acid alcohol. And that is the compound that accumulates in the eye and in the brain in these patients. So as a consequence, choosing between one or the other, they're probably, it's 6 to 1, half a dozen of another. I will say that the other potential problem with chemo is a fraction of patients will develop diarrhea with it, because it's a dihydroxy bile acid that actually is diarrheagenic. And also a small fraction, about 10%, will have elevation of their liver enzymes from therapy with chemo. That's probably the major difference between the two compounds. So there are questions I can answer for you? So from a functional standpoint, probably the most important message I can give to you is that our experience and the French experience, which actually was published recently, and our registration trial hopefully will be published in JPGN in the next year, that is in 2017, not 2018, is that although some of the patients got treated with URSO initially, we abandoned the therapy because URSO interferes with absorption of cholic acid. And so as a consequence, we've always believed that cholic acid was more effective. And the reasons it's more effective is two basic reasons. The reason we believe patients have these diseases is, one, they produce metabolites that are injurious to the liver, and two, they don't have a bile acid pool. And unfortunately, as I alluded to, URSO does not suppress synthesis. And so you always want to suppress synthesis. There aren't any other drugs currently available on the market that will replace cholic acid.
No. We know that patients in treatment with URSO may mask the bile acid profile.
Right.
Is there any other drug that may do the same?
That's the only one I know of, because URSO and its metabolic profile can actually make it difficult to make the diagnosis. So there's not any other drugs that I know of.
Okay.
I don't want to confuse things, but what about having a normal GGT? Is that you can still have the disease?
Oh, I would say, so I can tell you, we debate this. We're part of Children, which is a network that's sponsored by the National Institute of Diabetes, Digestive Disease, and Kidney by the NIH. And we debate always what is a normal or low GGT. Most of us now believe that if you have a patient that has a GGT of less than 100, which would be in the normal range or low, that's probably a reasonable cutoff. So the answer to your question is they're going to have probably mild, even the defects that we see, the difference really between these defects and MDR3 and alleles and other conditions that typically cause cholestasis is there tends to be less equivocation. So like an allegeal patient will maybe have a GGT of 400 or 500 and not near this range. So I think you have to be a little bit flexible about it because I don't think we know exactly the answer to the question. But certainly what you perceive to be near normal in the newborn period, that should raise a question about whether this is a bile acid synthetic defect. We debate about it for PFIC1, PFIC2 all the time in these sessions because nobody knows exactly what is perfectly normal.
Yo puedo traducir si alguno quiere algo puntual, ¿eh?
Apart from URSA, is there any other medication that may affect cholic acid?
There are probably not relevant things to pediatric patients. In theory, cyclosporin might interfere with it, but we're not even using cyclosporin hardly at all anymore. So I would say from a clinical standpoint, there probably isn't much of anything.
What about, it's going back to CTX.
Yeah.
I hear some comments, but I just want to see your perspective. And between cholic acid and chemo, one drug may be more neuroprotective and the other drug may be more liver protective. Is such a thing? Or?
I don't believe that's true. I think that the essence of effective therapy for CTX is suppressing cholesterol levels. And I don't think that in the concentrations or the doses that we typically give, there's probably much difference. And quite frankly, the important thing to remember is the reason it's important for us to diagnose CTX in childhood is to prevent the long-term complications. Because functionally, it's not a disease I would consider to be a liver disease beyond infancy. That's the only time they have any expression of any liver disease. So I don't think we're treating their liver. We're keeping them from developing more serious neurologic complications. So I have to give a talk at the Digestive Disease Week, which is it's a week from Friday, I guess, or Saturday. And I have to talk about disorders of bile acid and bilirubin metabolism that cause liver disease. So first off, I don't think there's any disorders of bilirubin metabolism that cause liver disease, from what I can judge. And even the defects that we see, I can very easily talk about 3 of the defects that cause liver disease. One is 3-HSD deficiency, 5-beta reductase deficiency, and the oxysterol defect. Those are the 3 for sure. The thing I'm going to actually present to them, because they're mostly internists, is the fact that in the newborn period, some of these patients are going to have other diseases in the bile salt synthetic pathway are being expressed as cholestasis because of their immaturity. And then beyond infancy, that all goes away. You had a question, Paul?
Yes, sorry, I go back to GGT, as we have been talking earlier. You mentioned that maybe GGT levels in patients with CTX and paroxysmal disorders could be
Elevated.
And I think it's important to mention it because these patients, however, or Repsum or adrenal leukodystrophy patients, or maybe CTX, although they have neurological symptoms, they could have liver involvement, and those patients could go to your hospital, or maybe the pediatric neurologist or some other specialist could request your help. And if you think that all the bile acid synthesis disorders have low GGT or normal GGT, I think that we could lose those patients.
I think it's clearly possible. I think the phenotypes of the paroxysmal disorders we should be able to identify, us and the neurologists and the developmental pediatricians. I think CTX is a little bit more difficult, but it's one that I consider to be a really, really important one to define, because patients who have CTX as adults are very, very debilitated with their neurologic disease. And the tricky thing about it is just thinking about that as a potential diagnosis if you don't know the answer. And there's probably You can't use serum bile acids to differentiate either of those conditions very well. So you can't look at their GGT, you can't look at their serum bile acids. You have to actually have a high index of suspicion if you don't have another diagnosis to look more aggressively. And I think the only ways to do it are basically either genetically or by FAB-MS or electrospray as methods to look for those defects. I can't offer you any better help than that, because I don't think there is any better help than that. If it turns out that they have a low GGT colestasis associated with them, it's easier, but I don't think that's necessarily true 100% of the time. I think there's a variation in the GGT levels. But I know for a fact, for 5-beta reductase and 3-HSD, they are uniformly have low GGT levels. So the take-home message today is, if you have a patient you have identified, you need to do whatever you can to get them on therapy with cholic acid, because it's the most effective way to treat them or prevent them from developing disease. I will say the other piece, the final comment I will say is, if they're on chronic therapy with cholic acid, don't stick your head in the sand. You need to watch them, because they have a metabolic disorder, and I don't know whether they're prone to carcinogenesis. So we're routinely doing alpha-fetoproteins after they're out 3 or 4 years, and then doing annual ultrasounds to make sure we're not missing something. We clearly have had at least 2 patients that have had neoplasia. One with a paroxysmal disorder, and I had a boy that we started treatment who had dysplasia before we started therapy. So we know these are very likely to be pre-carcinogenic conditions.
For many years ago, we used no cholic acid because Argentina don't have. And you use Utka, this acid. What do you think about the follow-up to this patient? This patient and the evolution, clinical, and the liver disease is the same?
Yeah, that's a great question. The natural history of the diseases are not perfectly well known.
Yeah.
We think that there's a huge variation in terms of severity. I think there are kids we've seen who develop liver failure early in life, particularly with 5-beta reductase deficiency as well as with 3-HSD, although we also know that there are adults that have presented with cirrhosis with it. So it varies a great deal by the patient. If you have patients who are on URSO now, I would really seriously consider switching them to cholic acid, because we know that'll suppress the production of the metabolites.
One of you, the clinic, with I think as the similar, but I don't know it's specific at the liver disease, no?
We have a patient with a reductase deficiency. He presented with liver failure at 4 years old. We sent the samples to the USA, and we had the confirmation diagnosis. And as we couldn't get cholic acid, we put him on Utica, and he recovered from the jaundice situation. His bilirubin is normal, and he recovered from the liver failure. And we follow him during 15 years, more or less. And well, he's an adult now, of course, and he's in the same situation with the cirrhosis, without any complication. But well, on this treatment, we couldn't offer him. Possibly, if he would receive cholic acid,
Right.
The situation would be better.
Potentially be better, yes, potentially. And so what you don't know is, and this was a child that had 5-beta reductase deficiency, is that what you said?
Yeah.
Or 3-HSD?
Also, no, yes,
Isomerase, yeah, okay.
Isomerase.
So the what you don't know is, in a certain scenario like that, is the child may have recovered from the newborn period, didn't appear to be cholestatic, and may have gotten something in addition, had acute on top of chronic liver disease, and that's what precipitated the failure. And so you may have been fortunate that things got better. That would not be a typical pattern you'd see with 3-HSD, because I would not expect you to see them recover like that. I wouldn't be surprised if you saw a baby in the first few months of life develop progressive disease to end-stage liver disease with 3-HSD, and particularly with 5-beta reductase for sure. So that's the problem, you don't know. And that's one of the things I think is likely to be observed over time, is that these kids will have smoldering low-grade disease, they'll have progression in their injury over time, then they'll get hit with something else, with acute on top of chronic liver disease, and that'll precipitate what you're describing. So that may be it. And you may have looked for everything in terms of the cause of fulminant hepatic failure, but there's always a portion that are indeterminate. Nobody knows.
¿Alguno tiene algún otro caso que quiere comentar?
Yo si me ayudas un poco.
Sí.
My English is not very good.
Well, you can speak in Spanish, and Mariano can translate for you.
I will try. I have 5 diagnosed patients. One is Goya, Goya
Yes, yes.
We have 2 on treatment. No. 2 on treatment and 1.
Are waiting for the medicine that is arriving as we speak.
Any moment.
That's the third one.
Yeah.
Gloria is perfect now.
Yeah.
She has 10 years old.
Yeah.
And it's perfect. In one occasion, she elevates the TGP, and I send a urine sample, but it's
It was
normal.
fine. Yeah.
Then the ALT become normal again.
Right.
I don't know what
So
happened.
this is another example where there's probably something intercurrent. Most of us now that have had experience with liver transplantation are seeing all kinds of crazy things happen. We monitor these patients so carefully. We'll see transaminase elevation. We'll have no idea what the cause is. Our immediate reaction is it has to be acute rejection. And in fact, it's probably some intercurrent viral infections that we're unfamiliar with that are causing these things. And for that reason, it's actually causing everybody incredible anxiety. But you did exactly the right thing. That is, you should monitor them. If you see their enzymes elevated, you should follow them until they normalize. And also make sure they're compliant. And the most simple way to do that is to have a urine study done.
Yo quería comentar eso y bueno, tuvimos un poco de diferentes formas de clínicas de presentación. Eso
So we have different ways of presentation.
Uno de los pacientes que se presentó
One of them,
con una colestasis, una hepatopatía crónica antes del año de vida,
chronic liver disease, cholestasis.
pero por una intercurrencia infecciosa desarrolló encefalopatía y requirió trasplantarse antes de que recibiera el ácido cólico. Estábamos tramitándolo.
So the patient got acutely ill and developed hepatic encephalopathy, but that was associated to the infectious complications.
Right.
Y requirió trasplante.
And required transplant.
Yes.
So
Estábamos ahí a punto de comenzar con el ácido cólico, pero bueno.
it was a little bit of a delay in the delivery. Anyway.
Well, all I can say is we don't know the natural history of the disease perfectly, but we do know in the 90s when we went over to Bicetra to actually study the first 6 patients from Bicetra, there were siblings who had previously died that clearly had these defects, and then we had some older kids that had evidence of fibrosis or cirrhosis that had been untreated. So we know that appears to be the natural history of the disease, but it's obviously quite variable.
Alejandro, ¿quieres comentar un caso o no? No.
Zona de Bile, pero bueno, eso no es una situación.
So no question is silly if you have a question. I'm going to be back here in September, but you may not see me then.
Because el doctor Dr. D'Agostino will have an event por muchos años de trasplante, el primer trasplante en el hospital italiano, y Dr. Heubi will be there, so he will talk about other topics, I believe.
Okay.
Me voy a poner del lado del diablo. Como ustedes saben, yo vivo en Colombia y tengo algunos médicos que me plantean, bueno, pero prefiero trasplantarlo y no tratarlo. Entonces, porque no sé, ya, a veces me dicen eso para...
Whatever she said you didn't like.
Cambiar una edad por otra, porque no me voy a tener que ir como supervisor. Not here, I prefer to perform liver transplantation than treat this patient because I almost have a cure for this disease with the liver transplantation. What do you think about that?
It's a simple answer for me. My attitude about liver transplantation is, having done it for now, I started on our team now 30 years ago. All we're doing is trading one disease for another. And the infectious complications and other problems associated with transplantation clearly are much, much more dangerous than treating with cholic acid. If you look at it from an economic standpoint, it will take, depending upon what cholic acid costs in Argentina and South America, it doesn't take too long, assuming your patients don't have to pay for it, for the government or some third-party payer to say it's cheaper for me to transplant patients than to treat them with cholic acid. But the morbidity and mortality associated with transplantation is always going to be greater than the therapy with cholic acid. We did not have any role whatsoever in the pricing of cholic acid. It had nothing to do with us. We just brought the drug to market.
So, but there's few medications that are so effective.
Yes.
Because there's many lysosomal storage disease disorders that they have some treatment, and some of them have marginal effect, but this is a striking effect. This es un efecto que cuando está cambia radicalmente la
Yeah, so I was going to, part of one of my slides that I have is that the Institute of Medicine in the United States in 2010 picked out the treatment with cholic acid as being one of the examples in which we could specifically cure an inborn error of metabolism.
It reminds me of nitisinone.
Yeah.
Okay.
Thank you for your attention.
Thank you very much.